All right.
November 15th. I'm sure there's still.
All right, guys, we're gonna get started. We're gonna get started. So, everyone, please welcome Dr. Orlando. He works in UF Health. He specializes in family medicine, and he was kind enough to come out and share his expertise with all of us. And the truth about coronavirus, there's no one better to ask but an actual doctor. So before he gets started, Raquel is going to come around and just take your attendance. So she's just going to get your name and your email. But yeah, all right, so everyone please give Dr. Orlando undivided attention. Please don't talk. Let's give him the same respect that he gives all of us. So with that. All right, 1 second, let me put it in. Do you have any videos?
Yeah.
No, okay.
So thanks for inviting me. I met Carter earlier this year. I had some interest in your club because I had come to see Charlie Kirk speak last year, and I thought that put on a great program for him. And I've just been inspired by the social media, TPUSA, and this has kind of been on my mind for the past year, so it was really nice to have an opportunity to put something together like this for students. I'm going to speak from the position of science, and then at the end we can talk more about, opinion. But anything I say is or what I say that we don't know is just going to be based on the science background of COVID. So I do work in family medicine, so I do treat COVID patients, but typically in an outpatient setting, not in a hospital. And we see them all on telemedicine. We don't have any patients come into the clinic. Can I just have a show of hands who is a science major?
The hard science.
Okay, so how about this? How about biology, chemistry, physics, and calculus? Okay, soft sciences, non-science. How about we go around the room? Just tell me your major. That would be the best way.
Computer science, minor physics, food and resource economics, sustainability and architecture.
I'm a business pre-med.
Pre-med biology.
Pre-med bio. Pre-med bio. Sample engineering.
Political science. Business and political.
Nursing.
Chemical engineering.
Construction management.
What's your
Me.
Oh,
Oh,
sorry.
sorry.
Chinese and business.
Cool. Okay, great. So I think there'll be a little bit of something in here for everybody. So what are coronaviruses? So coronaviruses are RNA viruses. That's kind of the technical term. They have a positive sense strand, so the RNA can just go right into being translated into a protein. They infect typically or primarily the lung epithelial cells, but also the cells that line all the mucosa from the upper respiratory tract down. And they also do infect somewhat the GI system. They're tiny, 100 nanometers. They have some spikes on the outside that we'll show you a picture of. They can cause disease in a wide variety of mammals and birds, not just humans. So the human coronaviruses, there are 7 total. These are the 4 that typically cause the common cold. So the 50 to 30% of the common colds, upper respiratory infection is from coronaviruses. And occasionally these viruses can cause pneumonia, but not typically. Classically, it's the runny nose, cough. The 3 other coronaviruses are the ones that cause more severe disease and epidemics and pandemic in the case of COVID-19. So they are SARS-1, which caused an epidemic starting in China in 2003. MERS, the outbreak started in Saudi Arabia in 2012, and then SARS-CoV-2, or a novel coronavirus, started in December in China. So this is how the coronavirus infects the cell. It enters the cell. This is the RNA. The RNA immediately starts to make protein using the machinery of the cell itself. Then it starts to make its own RNA, and then make the capsid for the virus and then ship out more viruses. So it's very simple, but at the same time, very, very complex to be able to enter the cell and use the cell's machinery to make its own self and infect other cells is not a simple endeavor. So the SARS-CoV-1, this is kind of a little bit of a prelude to COVID-19. The case fatality rate was about 3%. It initially was found in these exotic animals. I believe it's pronounced kivets. Has anyone seen that animal? No? It's a little furry creature. It was in a food market in China. So they thought it was zoonotic, so they initially slaughtered a bunch of these animals, but then they found them in many other animals and in bats later during the epidemic in 2005. They found that coronavirus in bats, but they couldn't replicate the virus in human tissue culture. So what they did was they changed that spike on the outside of the virus to one that attaches to the human ACE receptor, and then they were able to then cultivate the virus in tissue culture. So this study kind of showed that, you know, if the virus could evolve in such a way to get the receptor for human ACE, which is a receptor on the outside of the human cell, then it could enter the cell. But just as a bat coronavirus, it couldn't get into the cell. So this is what electron micrography of a coronavirus. You can see these are the little red puffs or the spikes. This is kind of a schematic of that and shows how it binds to the ACE receptor on a human cell to get inside. And this is another stabilizing receptor. So theories on the cause of the COVID-19 outbreak. The scientific community, by and large, accepts the fact that COVID-19 was not manipulated by any human means. And so this next group of conspiracy theories show what those manipulations could have been if they found scientific evidence that it was manipulated by humans. The possibilities were raised that it was derived from bats in a lab, and then accidentally a researcher was exposed and then passed it on to the community in Wuhan. Some people, some scientists in particular, believe that wealthy people released the virus to increase vaccination rates. This is known as the pandemic that was taken off of social media by Dr. Judy Mikovits. And then another theory is that it was particularly created specifically to be used as a bioweapon. So there's a publication in Nature that pretty much refutes the fact that it was a manipulated virus, saying that it's a wild virus and that it must have evolved to go from bats to humans. But there are a few PhDs who they don't have a publication specifically that I could find, but there's some web media of them kind of refuting the Nature publications, and giving their theories why it could have come from the lab, basically. But by and large, it's not accepted to be a lab-derived virus. It's accepted to be evolved from nature. So how do you get it? So we'll kind of go through these a little quick because I think by now everybody's pretty certain that it's airborne. It can also be passed in feces, and the easiest way to get it is when you're near somebody who's aerosolizing mucus and they're infected. So coughing, sneezing, but also it's passed in feces, so flushing the toilet. You know, places that have very poor circulation, like bathrooms, can be super spreader locations, although I haven't found any studies that say that, but it is passed in feces, which is why hand washing is also important. But the CDC kind of changed their guide, saying that, you know, in the beginning of the outbreak, you know, surfaces were thought to be one of the main drivers of infection, but now it's much less so. It doesn't mean don't wash your hands. It just means that it's airborne primarily and then surfaces probably secondarily. Entering and exiting public transport like airplanes. So any place where you're stopping in a crowd. So airplanes tend to be actually a safe place because they have very good air circulation, and there are many studies that show this. It's just the actual part of getting on and off the airplane or being in the terminal that's going to be your highest risk of travel. So these are the symptoms. The number one symptom is fever and chills. Doesn't mean you can't be asymptomatic. There's a slide for that. It just means that if you're going to have a symptom, the most common one is going to be fever, chills, then cough, then shortness of breath, and fatigue, and so on. They did add change of taste or smell as a pathognomonic sign of COVID, meaning if you have it, you have one of the other symptoms, there's a higher chance that it's COVID-19. And some of these symptoms, like the loss of taste or smell, can last long after your infectious in days and sometimes months. And GI symptoms are also, while they're not prominent, they are a feature of the virus. Yes. Oh. So the next slide's on asymptomatic spread. So about 1 in 5 people who are infected are asymptomatic, so like about 20%. They don't transmit the virus as much as somebody who's symptomatic, obviously, because they're not producing as much mucus, they're not coughing, they're not aerosolizing the virus, but they can pass it on. But we don't, again, in the beginning of the pandemic, we thought that asymptomatic spread was pretty much how it was moving around, but now we're less certain of that. We really think it's probably mostly through symptomatic spread or minimally symptomatic. So super spreaders. So this is something that's come out more recently. POI, so points of interest. So the viral spread is being traced to specific locations and specific times and events. So, parties, events, or places where people congregate, restaurants, gyms. So there's an interesting study where they track people's cell phones and also incidents of outbreaks. And they were able to see in Chicago that super spreader events accounted for most, let me see, a small number of locations accounted for most of the events. So of the locations that they had, 10% of the locations accounted for 85% of the infections. So it means that if you're just kind of in a low risk situation, the chance of you getting it is close to zero. But if you're in a high risk situation, the chances go up, remarkably. Let's see. So also they showed that it's known that the rate of infection is higher in lower socioeconomic groups. So this study also confirmed that. And they had some theories because of being able to track mobile cell phones that disadvantaged groups aren't able to reduce their mobility as easily. It's harder for them to work from home. And they tend to congregate in areas that are more crowded, just based on the study. Yeah. Okay, to mask or not to mask? That is the question. So, what do you guys think? How many for masks? 3, 4, maybe 5. Okay, so everyone else is not for mask. Okay. Does it matter what type of mask?
Yes.
Yes.
Okay, you guys are smart. So here's the scoop. Masks can help slow the spread, but they're not a replacement for social distancing. So the primary reducer of spreading the virus is going to be social distancing. It doesn't mean like 100% lockdown, like people stay at home. It just means the super spreader idea is that you go to a place that's crowded, the chances go up even if you're wearing a mask. So you shouldn't think, well, I have a mask on and it's safe, which is what most of you didn't raise your hand. Yeah, that's true, because social distancing is going to prevent most of the infections. But the mask does reduce the risk of infection, and if you want to reduce your risk as much as possible, especially if you have to do something that's important, like go to, shopping or whatnot, then you should wear a mask. But if you're alone or you're outside where there's not a lot of people around, the chances of getting it is low. You're safe. for the most part, you know. You don't need to wear your mask in the car when you're driving or just walking on the sidewalk. If you walk past someone and they have COVID and they cough on you, well, that's not good. But if you walk past someone and they're asymptomatic with COVID or they don't have COVID, you know, chances of you get it from just walking past them is no. So if you walk past a healthy person, even if they're asymptomatic with COVID, the chances you're going to get it is close to zero. So, you know, what does that say for, you know, public health measures? I mean, there are probably some places that are more strict and some places that are less strict, but in general, I think that a balanced approach is the most important. So let's see. Oh, the valve. Yeah. So if you have the valve, have you ever seen those ones with the valve? I mean, that's not helping anyone around you, just to let you know. May make you more comfortable, but it's not helping your peers. So the, let's see, wear a mask when you can't socially distance, unavoid unnecessary risk. So unavoid unnecessary risk because no mask prevents infection 100% of the time. Matter of fact, what are these people preventing? Well, what's common about all of them?
They're outside.
They're outside. Say again? They're wearing masks, but maybe not properly.
They're
They're
not
not-
social distancing. Really.
They're not, well, that's true.
They're more worried about COVID than brain damage.
Yeah, they don't have a helmet. They're probably going to die from a head injury, and they're not going to die from COVID, you know, unless their neighbor coughs on them. But anyway, so this is kind of the mentality of some people, and that's fine, but it's not really, you know, what's the point? Okay, so which mask? So wear the best mask you have. And the N95, they want to reserve that for healthcare workers. I mean, if you have one, great. I mean, it's kind of hard to get and they may be more expensive. They will reduce your risk of getting infection more than the other masks, but it's 95% of particles are filtered. And again, the more you're around somebody and if there's an aerosolizing event, that's why healthcare workers that do procedures like intubation or bronchoscopy, they'll wear something that covers their whole head, you know, because just the N95 and eye protection, because just N95 doesn't do it 100% of the time. So there was a big study, meta-analysis that shows that N95 is not better than surgical masks for healthcare workers in non-aerosolizing settings. So there's even a large study that shows that this mask and an N95 is not any different if you're not in a very high risk situation where someone's coughing and making clouds of mucus. Let's see. Add eye protection. Yeah, if you can, if you have to travel, like if you have to be close to people for a long period of time, eye protection is a good idea. I mean, not just glasses, but the full type of eye protection. I mean, if I personally was going to travel on a plane to somewhere, that's what I would wear. I would wear N95 goggles or a surgical mask and some sort of eye protection. So surgical masks, it's more protection than most cloth masks. There are studies that show that. They just filter more, but obviously, I mean, they're open on the sides and they're not quite as dense as N95, but they are better than the cloth mask for protecting you. And then the cloth masks and face coverings, they're not all equal. So the thin gaiters that you see people wearing, they pretty much don't, if you look at this study, they almost do nothing for the person. They may prevent some, airborne particles for other people. They're really not helping you. If you have a thicker cloth mask, it can approach the protection percentage of the surgical mask. So not all masks are created equal. So you guys were right there too. Masks work, but they are not infallible and therefore keep your distance. Disinfectants. So here's a list of disinfectants you can find online, the EPA. One great one that people kind of overlooked early on and is hydrogen peroxide. I mean, people wanted to take up all the ethanol by the gallon at Home Depot. The problem with ethanol is that it evaporates too quickly. So if you want ethanol to work, you have to mix it with the gel so that it doesn't dry as fast. Even other alcohol-based preps, you have to leave them on for more than 5 minutes. Hydrogen peroxide is nice. You only have to leave it on for 5 minutes. It's not really toxic. It could bleach your clothes potentially, but it's pretty benign and it was easy to find. So if you have hydrogen peroxide, you can use that. Reinfection. So there are some studies now that are showing that reinfection is a reality. There are not a lot of cases, but there are cases of reinfection. And some of the reason we'll talk about is probably due to antibodies, which is a slide towards the end. But some viruses you get once and you're done. Like the herpes virus, all 8 of them. I mean, you carry them with you for life, and some of them get reactivated, but you're pretty much immune once you get it. The same thing with other viruses like influenza B, some influenza A's, so influenza changes every year because our immune system makes antibodies to previous year influenza A, but not so much for the coronavirus because there are cases of reinfection. I referenced one of a 25-year-old who actually didn't have an immune disease. He was a young person, and they showed that he got, let's see this slide, yep, he got infected twice. They proved it by sequencing the genome of the virus. So does the virus mutate? Well, it doesn't mutate in the sense of influenza A mutates, where it mutates so that you're more likely to get infected by it. So you need another vaccine every year. But it does change its genome slightly, particularly when moving from continent to continent, or even now they're seeing when moving from area within the same continent. Like this group was in northern Nevada, and they sequenced the second virus that he had, and it was significantly different. So it actually changes a little bit, enough to tell that there's a difference, but it may not confer a virility, benefit for the virus itself. But we can tell if you had a reinfection in that regard. So it seems like it's not a very high risk, but it appears to be happening. And there's a lot of studies that are happening now about just targeted about that, specifically reinfection. So now we'll talk about mortality and death. These are the leading causes of death in the US in 2018. Cancer, unintentional injuries, chronic lower respiratory disease. So COVID right now is somewhere in between cancer and accidents. It's between 200 and 300,000. So influenza is way down here, 50,000. And people die from influenza from the secondary pneumonia. So the current population is 330 million. One birth every 8 seconds, one death every 10 seconds, an immigrant every 47 seconds, one person every 27 seconds we gain. The total deaths in 2018 is about 2 million. So I just gave you those numbers to kind of break down an idea of like, what does it really mean, these statistics, just looking at it from like a more national perspective. So when they talk about mortality rate, so that's the number of deaths that occur in a population in the US. So for COVID-19, so we are right about 274,000 deaths, is 330 million. So the mortality rate is 0.08%. The COVID-19 world mortality rate is 0.01%. So fatality rate, that's another term in here. So that of the people who are COVID positive, how many of those people die? So in the US, so same number of deaths, but then these are the positivity rate in the US so far, 13.9 million. It's 1.97% of people who are infected with COVID die. And then in the world, fatality rate is 2.3%, and then for influenza, 0.21%. So there is a difference between influenza and COVID-19 as far as the fatality rate, quite significant. But the thing that's interesting about this number is that they estimate it. They estimate that 35 million people get influenza because they don't have all the tests. The COVID-19 rate of infection is determined by positive testing. So the influenza rates are estimates of how many people they think get influenza every year, because we test a lot of people, but that test doesn't go to like the CDC or the World Health Organization. And then towards the middle of the epidemic and flu season, we stop testing because we just say, this person has all the symptoms of flu, we're gonna treat them for flu, they're high risk or they're low risk, you're gonna be fine. So this is an estimated number, so it could artificially potentially deflate the fatality rate. But still, as best we know, it's significantly higher, the COVID-19 fatality rate than influenza. Let's see, so the other interesting thing about fatality rate is when you try to compare countries, people like to do that all the time. Well, this country is this and that country is that. Well, great, but how do they
how do they do the tests? You know, are they testing everybody? Are they testing symptomatic people, asymptomatic people? So, or are they testing it all? You know, or are they reporting the test accurately? So it's really hard to compare countries, which people like to do all the time. There is some indication more recently. There's some articles I've seen where they feel that the fatality rate could be going down a little bit. And they give theories, you know, we don't have a miracle drug, but maybe our treatments are a little bit better. Some of the demographics are changing of who's coming into the hospital to be treated. So some studies are showing maybe the fatality rate is going down a little bit. So these are the current graphs that I just pulled up today, just so you get an idea. The problem with these graphs are it's hard for even me to find really good graphs online. And Carr said that, well, it's great to have an MD talk to you about COVID-19, but I would say that a bioinformatics statistician would probably be the best person to tell you, or an epidemiologist, about COVID-19. Those are the people, those are like my friends right now, and I want to ask them questions. So one of the problems with these graphs is that they're too close. They need to back up. Because when you get close and you see something like a spike, you're like, whoa, look at that. But when you back up, you see that like, wow, that's nothing. Like the stock market. You can go back and look at the stock market since like its inception. When you go back and when you change the graph and look at it since its inception, you're like, man, this divot here is like, no big deal. I mean, you know, look at it like, you know, 50 years ago. It's like, you know, and look at where we are now. We went down a little bit, but now we're up again. So it's kind of like that. We need to take a step back. So it's hard for me even to get good graphs, but these are the current graphs. So this is US cases and deaths. So US cases, US deaths. One thing you notice about the graphs, up and down, up and down, up and down. It's always going up and down. It's not flat. So when people say we're going up, it's true. But you know, when we were going up here, I'm sure people were, you know, very emotional about it and deaths, but then it went down. So it's going up again. It's hard to predict. It just really is. You just kind of have to take a step back and say, well, why is it going up? And the thing with COVID is it went up because something happened 2 or 3 weeks before. So it's hard to say, you know, what's going on now is it's not what caused it to go up. So epidemiologists and biostatisticians, like this is their area, so I won't pretend like I know a lot about these types of statistics. But it looks like we're starting to slope down a little bit in the US, slightly, but we have to see a little bit longer. This is Florida. So it does look like we're at a peak, but we may be on the backside of it. This is in the world. And we're only going back to July with these, so it is a little bit harder to interpret like that. But it does seem like we're kind of on the backside of a peak. So, quality adjusted life years. Has anyone ever heard this? Yes. What's your major?
Computer science.
Computer science. Cool.
So not related, but
Not related. I thought maybe somebody also in the business sphere. So, this basically is a way to, I don't want to minimize the death of anyone. I had a close family member in New York pass away from COVID-19. But at the same time, I think if we really want to look at the situation in an aggregated fashion, we have to look at all aspects. So one aspect is what I just showed you, like, you know, how many people are dying on a daily basis. But the other aspect to look at is how are our behaviors affecting our lifespan 10 years from now, 50 years from now, 100 years from now. And that's where this statistic, this number or this factor, what it tries to look at. It's called quality adjusted life year. So basically it says is, you know, one of the things they examine with it is what is the cost of economic shutdown, not just monetary cost, that's part of it, but also a cost to your health. Because when people are isolated, things happen, you know, their health, they don't go to the doctor to get their cancer screening. Maybe they are depressed and now they become suicidal. Maybe they were in a relationship that was a little strained and then it becomes domestic violence. So, you know, economic shutdown doesn't come with a cost. So people want to just say, yeah, shut it down because, you know, it's going to reduce the number of infections because you just told me social distancing is the best way to reduce infection. Yes, and also, you know, if you take a look at the big picture, it's not the whole picture. So yeah, so this is one way that you can you know, and again, it's mathematics, so it's not exact. You know, if we have a death rate for today, we say, okay, that's a fact. If we look at probably adjusted life years, we're kind of doing math. So, but it's a real thing. You can see it happening in the community, and I can see it happening with my patients, how isolation can affect people. So this is the other side of the story. Congressional Care Act. So you hear in the media about, like, you know, they're changing the numbers, you know, because they get paid to make it seem like more people have COVID. Is that true? Yes and no. So the truth of the matter is that the government wanted to help hospitals that were treating a lot of sick COVID patients, because those areas that had a lot of COVID patients may become financially strained and might just make the situation worse. So they tried to pump money into areas that had high COVID death rates. So initially they were only looking at positive, you know, true COVID positive death rates. And then later they had a stipulation where if the person was presumed to have COVID, you know, that would add to the, you know, to the number of COVID patients they treated. Because I have to be honest with you, you know, the COVID testing, sometimes it's not exact. I mean, there's false positives and false negatives. The accuracy is around anywhere from 70% to 89% or so with the COVID test. So, and some people aren't positive until like 5 or 6 days into the infection, and some people may die before they become positive. It's COVID. So they allowed it to be estimated. So some news articles, and again, this is not my area of expertise, but I found some news articles saying, no, people are not overestimating. And said, and said, yes, people are overestimating. They gave this one article, I gave an example of New York, where when they changed that stipulation, the death count went up. You know, I don't know if it's true, but I can just know from the sense of a doctor, I mean, I'm not getting paid more for treating COVID patients. It's more of a thing to help the hospitals and cities that have the most COVID deaths, and it makes sense to me. So being blinded from the next slide, blinded from science, the cost of false perception. So what would you say the age group 55 and above, what percent of deaths occur from the age group 55 and above?
Probably like 90%.
Great. So you would have been an outlier. Because the people in this, when they gave a survey, the people said that 55 and older accounts for about half of the deaths. And it's closer to 90%. You're almost exactly right, 92%. So Americans saw those age 65 and older accounted for 40%, and actually it was 80%. 44 and younger made up 30%, and the actual was less than 3%. If you're younger than 30, it's less than 3%. And your guys' age group, 18 to 24, 0.1%. So we really have to look at it from that perspective. So the researchers attributed to this discrepancy to partisanship and social media specifically. So when people believe this, they act differently. They spend their money differently, and they change their behavior. When that happens, you know, hysteria is kind of the more extreme end of that. But even before hysteria, can be other very bad things that can happen in the long term for society. So this is hospitalization and death by age. So this kind of gives a schematic. This is from the CDC of, you know, where are you? And this is based on 18 to 29. So that's your age group. So this is a perfect graph. So this is a comparison group. So hospitalization and death. So every decade, 4 times higher, 10, 30, 90, 220, 630 times higher, just by decade. So that's an incredible difference. So you really have to look at it from, like when I talk to patients, I mean, one of the things is we do a risk-benefit analysis. You have to individualize it, like what's going to be best for you. And you guys have to kind of look at that group. I mean, you do want to say what's best for my neighbor. I mean, it's definitely important. But at the same time, when we do health, we talk about health, we really talk about, well, if what's better for your neighbor is harmful to you, like, you know, maybe we should do that. You know, I mean, I'm really concerned about the person in front of me, about my patients. So we should take a similar approach. So the safety premium and inflation prospects. So I won't claim that I know a lot about this slide because it's more to do with inflation and business, and I really didn't study that much in school. But the take-home point is that this same study, they also asked people, okay, you're going to fly a plane for $500. if we can increase your safety, would you pay 100 more? Would you pay 200 more? Would you pay 300 more? And knowing what we just knew about that, I mean, if you were, 30 and you thought that, well, you had the, or say you were, 30 or 40 and you had the misperception that like, in this age group, like 30-40% of people will get infected or dying. And then you ask this question, would you spend 100 or 200? They may say yes. So all those people that had the misperception, they answer these questions like, yeah, I'm going to pay more, I'm going to pay more. 1 in 3 to 1 in 10 would pay 50% more for the flight. So what happens? Well, it causes inflation. Because the more people that are going to spend more, if they perceive that there's extra safety and it's worth the money, I mean, it could change the price of things. And it also could exacerbate inequality because when the price goes up, not everybody has the extra money to pay for it. So it actually causes more disparity. That 6%, has anyone heard this, the 6% statistic? So there was some fake news that came out that said, okay, the fatality rate is wrong, that actually it's only 6% of the nation's deaths were from, only 6% of the deaths were correct. Was what the CDC put out as a paper saying that 6% of people who died from COVID didn't have any comorbidity. They didn't have hypertension, diabetes, heart disease. So then some fake news came out and said, oh, it's wrong, 6% of what they're saying it is, which is not true. It just means that 94% of people who die from COVID are unhealthy, which is important for you guys to realize because primarily you're in the healthy group. So treatment of, this is the last part, we'll get into the treatment of COVID-19 and vaccination. So the treatment is supportive, drink fluids, stay hydrated. If you have shortness of breath, see the doctor because that's how people die from COVID. There's some supplements, there's some references, vitamin C and zinc have been shown to help shorten the length of COVID infection. Hydroxychloroquine, I'm gonna go over this really quick and just kind of give you guys the scoop. Most of the studies are showing that it doesn't work, so much so that they're not really studying much anymore. I did find one clinical trial, it's on the next slide, where they're still studying hydroxychloroquine. There were some studies that came out that said that hydroxychloroquine didn't work and it caused arrhythmias. Some of those were actually retracted. They published them too fast and they were just basically had bad data, so they took them out. So there's a lot of social media about hydroxychloroquine, but right now there's no articles that show that it works even for prevention. There's actually articles that show that it doesn't work for prevention. There's one trial going on that I could find. This trial said there's no benefit for prevention. The NIH has a bunch of trials, none of them show that it works. These are all very good trials. Actually, the NIH actually stopped one trial because it showed no benefit, and they felt like they were just harming people by continuing the trial. So when you see things like that happen, I mean, you know that. And this is multiple trials, multiple journals, multiple different groups. So you could say, well, this group was paid, and that group was paid, and this journal, that journal. But I mean, this is coming. I mean, there's a lot of studies that say that it doesn't work. But I'll make the very strong point that I don't agree with suppression of information. And there was a group of doctors who came out that said, we see that it's working. Well, that's actually scientific evidence, level 5 evidence. Personal observation by a physician is medical evidence, and we should not suppress that. We should not call it misinformation. We shouldn't call it fake news. So that really disappointed me when I saw the social media suppress those physicians and just saying, well, it's politicized. They're saying this because it's political. Well, I mean, I don't really appreciate that because that's actually science. Because that's how things start. It starts with observation, and then you have to study it and go higher and higher levels of evidence and do randomized controlled trials. Antibodies. So when you're wanting to think about, so we're going to go into treatments and then vaccines, and I'm going to start with antibodies. So this is a preprint, which means it wasn't published, but it has references to some published data, and their data specifically shows that the antibody response of asymptomatic patients, in more than 10% of symptomatic patients, that didn't last more than 3 weeks. So Some of it may have to do with the person's immune system. Some of it may have to do with how bad the infection actually was. And some of it, we just don't have the science yet to say whether getting an infection is going to prevent infection. And how do we know? We don't know what the antibody titers are. Like people on antibody tests, I have patients asking me, all the time for an antibody test. I can offer them a qualitative test, like yes or no, you have antibodies or not. What's the use of that? I mean, we don't even know if the antibodies protect you, and we don't know quantitatively exactly how many antibodies you need to be protected. So the data is not there yet. So monoclonal antibodies before you get to vaccination. So Regeneron, you heard that the president got Regeneron. Here's Regeneron. So it was just recently approved for emergency use. It's a combination of monoclonal antibodies of 2 different drugs that modulate the immune system and help the immune system fight off COVID-19. There's another one that was approved a little bit earlier that actually is going to be used soon, I believe, in Gainesville through IV infusion. Also approved for emergency use, basically in people with mild to moderate disease to prevent them from getting more severe COVID-19. And I mean, an N of 1, but it worked in President Trump, right? That was Regeneron. That was before it was even approved for use, but now it's approved. So vaccinations, who's going to be able to get vaccinated? So the vaccines are just about to come out. It looks like the government's going to restrict the use of vaccine for certain groups. And I found something on the Department of Health for Florida that says healthcare workers, yep, Florida Department of Health, healthcare workers and those who treat COVID-19 patients. I don't know if that's going to change. Again, this is just information I found online, but it makes sense to me. I've been thinking about this for a while. Like when it comes out, well, how are they going to use it? I mean, this makes the most sense. This is another one from this reference from Minnesota. They're saying, healthcare workers, first responders, older adults. So these are the vaccines in phase 3 trials. So the first phase is toxicity. The second one is toxicity and starts to see if it's efficacious. And the third one is primarily efficacy. So these are the ones that are in phase 3 trial. Pfizer just finished, I believe. So Pfizer, the efficacy they're saying, so the phase 1 trial is typically like 100 people to see the toxicity of it. And then when they do as the trials go up, it's more and more people. So phase 3 trials, this one was saying 30,000 people were tested with the vaccine. So they're saying the efficacy is about 95%. The side effects, no serious side effects, some headache and fatigue. The one thing about the Pfizer one is it needs to be kept on dry ice and it only lasts 10 days, which is not very easy to use. And right now they requested the FDA for emergency use authorization. So that's where we are with the Pfizer vaccine. Moderna, that's another one that's currently in phase 3 trial also. And the reason why I put this one is they did an interim review during the trial. It's not finished yet, and they found that the efficacy is 94.5%, and there's no major serious side effects that they're seeing during the phase 3 trial. Just have a couple more slides. I was missing something I wanted to talk about. Oh, here it is, vaccine development. I forgot to mention this. So this is an important side effect. I mean, it hasn't come up in the clinical trials, but it has come up in previous use in humans of the RSV vaccination. It's called, there it is. Vaccine-associated enhanced respiratory disease. So what happens is you get the vaccine. If you get infected with the virus, for some reason with the vaccine and the virus, the way they interact, it causes the lung inflammation. It makes you very sick. So they saw this when they tested SARS and MERS vaccine on animals and when they tested the RSV vaccine in humans. So they were very privy to this when they were testing the COVID vaccine, and they haven't seen any, that I can see, any significant events of this type of lung side effect from the vaccine. So that was one important one I thought of. People talk about Guillain-Barré. It's a very severe side effect of vaccination. The thing about Guillain-Barré is if you get influenza, you actually have a higher risk of getting Guillain-Barré than you do from the influenza vaccine. So you can say, well, I don't get influenza every year, I get the vaccine every year. Again, risk-benefit ratio, but those are kind of the two major vaccine side effects that people talk about is that lung one and Guillain-Barré. So the last couple of slides, just talk about if you get infected, how long you're infected, when can you go back into the population. So there's not really a consensus for, the main one that the CDC put out is for healthcare workers. The thing about with healthcare workers, they want healthcare workers to go back to work because they don't want to have a shortage. So, but I think it's interesting that they don't promote test-based strategy because I've seen it in patients that have RNA positivity for like months or two after, and they're not infectious. So for someone who's healthy, these are the kind of the basic criteria. 10 days since you got infected, your symptoms are getting better, and you haven't had a fever for more than a day, and you're not using Tylenol. Typically, you can be considered not to be infectious anymore. People can have cough for weeks after a respiratory infection, so based on this, you don't have to be asymptomatic, but it just has to be past 10 days. You have to be getting better and no fever for a day without medication. These are some interesting resources. If you want to look for studies, if you really want to find the science of COVID-19, I would look at studies. Or if you're bold and you want to interpret the data yourself, you can look at unpublished preprints. I can tell you this is the first time in my life that I've really read more unpublished preprints than studies, because when COVID started, there weren't any studies. But it was interesting to see how many studies either didn't get published or got retracted because they got published too quickly. So there is some importance. To be science, really has to be peer reviewed. If you've ever been through a peer review process, you know why. It's because it has to be a rigorous evaluation of the data, because people want to slip things in all the time that are not true just to benefit them. So thank you so much for listening. If you have any questions, I went a little bit longer than one, but thank you.
All right, so for about 10 minutes, we're going to do a Q&A. So anything you ever want to know about coronavirus, just ask Dr. Orlando. And keep it to 1 or 2 questions, and let's keep it brief so we can ask as many as possible.
What is the long-term harm to the body whenever you get the coronavirus, let's say from a mild standpoint to someone that has things bad?
So some people are having, lung disease that's lasting for months or even potentially chronic. It's called fibrosis. That could make you not be able to go back to work, not be able to really do much physical activity without getting short of breath or tired. This happens. It's not very common. And I think what the lowest, I haven't seen it in young people, but I think typically it has to do with the severity of infection, because the inflammation in the lungs is what causes the scarring and fibrosis. So I think in younger people, the incidence of the disease is low. It doesn't mean that there aren't young people getting severe infection. It just means that it's extremely low. So the risk of getting infection that's severe in young people is very low, and then the risk of getting that fibrosis is low. So it's going to be extremely low, but it can happen. I've seen at least one anecdotal case in an athlete, a young, healthy athlete who got COVID-19, and then after she had some issues with like getting back to her routine athletic activity because of the lung symptoms. So it's definitely possible, but it'll be extremely rare. If you get a mild infection, chances are you won't have any long-term side effects. The only long-term side effects I've seen in people with mild infection typically is the taste and smell thing, and sometimes last a while. You're welcome.
I read a news article that said that the vaccine will not protect against you getting COVID, it will just protect against you getting super severe symptoms. So is that true?
So you read something that said the vaccine won't protect you from getting COVID. It'll protect you. It'll reduce your how symptomatic you are.
Yeah.
So in part, that's how vaccines can work for some people. So the thing about vaccines is it's not like black and white. So it produces an immune response of antibodies. If you have a good immune system, or even if you in particular respond that way to that vaccine, if you have enough antibodies, the chances that you're going to get an infection are lower than if someone has a suppressed immune system, or someone just doesn't react well to the vaccine. They don't make enough antibodies, and then they get a very low symptomatic infection, even though they're vaccinated. But that infection is not enough to have symptoms or to spread, really shed much virus to others. So that's goes on with all vaccines pretty much, to one degree or another. And some of it has to do with, like, your age, if you have any chronic conditions, but some of it just have to do with people specifically, how they react to that vaccine.
If there's like no symptoms, if for instance, like the Pfizer vaccine gets, like people are taking that a lot and stuff, and if I got COVID in like October, and I belong to like the clade in South Florida or whatever, like South Florida or like North Florida, whatever, will the vaccine give us like the memory cells that would be associated with all the different clades in like America or like different regions of Europe as well? But like, how does the vaccine work in relation to the different clades that make up the COVID? You know what I mean?
Yeah, no, I know what you mean. So the area in the genome that you can tell different clades is not an area of the, as far as I know, the virus that affects its virility. The antibodies specifically, in my best knowledge, is to the spike proteins. So those are universal. So it doesn't matter where, it's not like influenza where that we can tell yet where there's some mutation, and it's so different that the antibody we're making with the vaccine is not going to work. It should work across the board. How long the antibody response is going to last, that I don't think anybody knows. So I think it really would have to be with how long we're going to be able, if you get the vaccine, how long you'll be able to produce antibodies, and not so much if the virus will change. I mean, it's changing, but not in a way that should affect the antibodies.
Just because the young person, like you were talking about how the clade that they got was different when they got reinfected like a few months after.
Good point.
You know what I
Yeah.
mean?
So he had antibodies to COVID, but he didn't probably have enough to
Okay.
prevent infection. It wasn't like it was a different virus, but it wasn't so different that the antibodies he had didn't work. He probably just didn't have enough of them.
Okay.
The best way I can explain it.
Okay.
I heard that it might never go away, the virus, and there'll have to be like yearly coronavirus vaccines, like kind of like the flu. Do you think that's what's gonna happen?
So if that's the case, I think it would have to do with, the issue. So the thing about studying the vaccine is, so they give the vaccine, but they're just looking at it over months, right? So they don't know they studied, the way they're able to determine efficacy is the number of people who were COVID positive in both groups, the vaccine group and the non-vaccine group, it was mostly in the non-vaccine group. So they could say that it works now. But again, this is only in a several month period. So I think the issue would be in a year is, do the antibodies last long enough, and how many people do the antibodies last long enough? And so if people get vaccinated and some people get infected and have immunity, because most people that get infected will have immunity, just based on the data we have so far, is that going to be enough to suppress the virus enough that it disappears? That's a very good question. So I think there's two things. Will you need to get another vaccine? So that one would be, so there's two answers to that question. One, do the antibodies last long enough? We don't know. And then two, will the virus disappear? So that means that will enough people get vaccinated or have the infection such that there's no more human host for the virus, and it disappears. So I don't know the answer to those two questions, but that's what studies would have to be looking at specifically.
Donnie.
Oh, yes.
Hey, I'm not really a health guy, more of a business guy, but coronavirus has been around. COVID-19 is just like a specific strain of that. Is that correct?
Yes, you could. Yes.
Okay. So why in the past has never been a major pandemic problem for coronavirus in general. And now all of a sudden, obviously, like COVID-19 has become a pandemic. Why hasn't it spread with like the other strains?
Sure, that's a great question. So you saw the slide at the beginning with the,
I might have missed that. I came in.
okay, no, that's fine. But I didn't really answer that question.
Which one was it? I can bring it up.
It was where it came from, how did its cause.
Yeah.
Yeah, it's the bottom three.
Okay, yeah, I missed these slides. Sorry.
No problem.
Just the right one.
Yeah. Here, theories on the cause of outbreak. So the scientific community is almost unanimous that it evolved, that it's zoonotic, right? So
What is zoonotic mean?
it means when an infection basically jumps from one species to another. So from one animal to another. So why did that happen? So, I mean, it's because of the interaction we've had with animals, basically. So, the theory is that it came from bats primarily, or kivets, which are a type of exotic animal in the Wuhan meat market, where people were buying this meat, and so that process going on for years and years, and the virus coming into contact with humans when it's primarily in an animal, a virus that also occurs in humans. There are coronaviruses that are known to occur in humans. There's coronaviruses that are known to only occur in animals. So, and they did a study in SARS-CoV-1 where they took a bat coronavirus and could not infect human cells with it in a tissue culture. They had to change the receptor on the cell. So they changed the receptor and then it affected. So the theory is that, that relationship between, humans and those exotic animals for over a period of time, and the virus just moved from one animal to another, basically. It evolved.
So it just became more effective at infecting people.
Yeah, basically.
Whereas
improving
we feel-
for survival.
Okay. And
Yeah.
we have more immunity to like the other strains that previously kind of existed.
So the difference between the four coronaviruses, let's see. Okay, so these four coronaviruses cause the common cold. And these three coronaviruses, SARS-1, MERS, and SARS-2, they cause a severe respiratory syndrome, severe acute respiratory syndrome. So why is that? The immune system reacts more heavily with those specific coronaviruses. So it causes lung inflammation, and it causes that syndrome which is lethal, basically.
Okay.
Yeah, and not with the other coronaviruses. It's mostly just the upper respiratory tract, like common cold, cough, runny nose, sore throat. And this one goes into the lungs, and it causes severe inflammation. Good question.
You said that initially the SARS-1 couldn't infect humans, but then it mutated.
That one also jumped. Yeah, that one's also zoonotic. Yeah, that one. So they thought it was in civets and kivets, and then they later on they decided it was probably moved from bats for whatever reason. Yeah. Yes.
I just wanted some clarification. So it was SARS-1 that they tested in a lab to make it where like it affects humans. So was that the reason for the outbreak for SARS-1?
Because of the lab? No, that was after the fact. Yeah, so that one, so SARS-1 was in 2003. Where is it? Yeah, 2003. Here's this study was in 2008. They were trying to figure out what happened, basically. And they discovered it in bats in 2005. And in 2003, they thought it came from kivets, and they slaughtered a bunch of kivets. But then later on, they also found it in bats. These coronaviruses are in many different animals, basically. So it just so happens that many of the animals it's in, where it's originating, both of them in China. I don't know the first one if it had to do with if they could trace it to like a meat market, but it has to do with the interaction of animals and humans. So, yes.
So we didn't really know about COVID-19 until December-ish, and then it didn't really become like a big issue in the States until like I want to say like February is when it really started to pick up and everything started shutting down. thinking about like the timeline of the development of the vaccine, and it seems very rushed compared to other vaccines. So like, I understand like how like the different phases of vaccine development are, like phase 1, phase 2, phase 3, but timeline wise, does it seem like have other vaccines been developed this quickly with like other diseases, or is this kind of like the first time you've seen it happen?
That's a good question. So, I mean, historically, it's hard for me to say, but I think that I agree with you. I mean, just based on my knowledge of medicine, I don't know another vaccine that's been developed that quickly. So, I mean, a lot of people have hesitancy for that reason. And, well, I mean, in a sense, you know, it's going to be offered in a staged way, which I think is best anyway. But at the same time, you know, if somebody comes to me in my office and they say, should I get this vaccine or not? I mean, the thing we have to discuss is risk-benefit analysis for you. You know, the CDC recommends everybody get the influenza vaccine, and I need to tell my patients that. But at the same time, you know, the CDC is not in the room with me and my patients, so I have to counsel them on an individual manner as well as like on a global manner. So that's why we're the Department of Family Medicine and Community Health. So on an individual manner, you have to look at like what's best for you. So if your risk of getting it is very low, and then on top of that, the risk of having some, you know, lethal severe case is also very low. You know, is the risk of getting a vaccine that came out really quickly higher? Maybe, you know, might be. Do you have one question?
Yeah, so my question is just where like does the science come in of like mass shutdowns, like government shutting down entire economies, telling everybody to quarantine, like how it initially started, where when you look back at like other pandemics, like the 1968 Hong Kong flu, like I don't think that was a thing back then. That killed like 1 to 4 million people worldwide. So I'm just wondering like where that kind of came in, if you have any understanding from like a science perspective.
Yeah. So the thing with coronavirus, like let's compare to influenza. You know, would for influenza, you know, shutting down like businesses and whatnot work? No, because of the way influenza spreads. Typically, people are infectious with influenza. The driver is pre-symptomatic spread from influenza, whereas with coronavirus, it's not so much. The way coronavirus spreads is going to be, you have to be with someone for a long period of time. Whereas with influenza, it is a kind of thing where they can cough on you and you can get it, just to really simplify it. Whereas with coronavirus, you're going to have to spend time with them. So that's why social distancing works, because if we go out in public and we spend a lot of time outside, chances are, you know, it increases our risk of getting it. Whereas influenza, you know, if we just like stay inside and we go out one time and we walk past a person with influenza and they cough next to us, we're going to get it. You know, with coronavirus, you know, if somebody with coronavirus walks past you, you're probably not going to get it. You know, even if they cough on you, chances are lower than with influenza. So in that regard, social distancing works better with coronavirus. And I think with a pandemic, it also works because when a pandemic starts, it starts in one place and then it spreads around the world. So the idea is like when an epidemic starts, you know, you should try to isolate it, you know, initially.
Right, but I thought traditionally you try and quarantine the people who become infected rather than quarantine like an entire society or groups of healthy people.
Mm-hmm.
And that's kind of just what social distancing kind of seems like. If you, like you just said, it's harder to get coronavirus unless you're around people for an extended period of time. Whereas if you get coughed on or whatever, and you can catch the flu a lot easier. So it just seems to me a little bit weird how like it's harder to get, but you have to like I don't like I'm.
So you're healthy. If you go to like, you know, did you see the super spreader slide?
Yes.
So it's kind of like that. You are healthy, but if you go to a place with a lot of people for a long period of time, that's how you're going to get it, period.
Right.
So that's why they want all the healthy people to not go into groups.
Okay.
Whereas with influenza, you know, you can just be walking down the street and someone coughs on you, you're gonna get influenza. So that's why social distancing really isn't working with influenza. But for some reason, because of the nature of coronavirus, it works. It does reduce, but there's a balance. Because of, like I said, talk about economic shutdown also reduces people's lifespan. And also wearing a mask, it does allow you to move a little bit more freely when you can't socially distance. So it's kind of like it all works together. That's a good question. Yes.
I heard that if you don't have the virus, then wearing a mask can like increase your rate of like getting infected because of like all the touching on the face and stuff. You know what I mean?
Yeah.
And also I saw somewhere before also, I don't know if it was refuted, but like that like you breathe in kind of like more of the air like stays here kind of something like that. Like what about that? And then also I was gonna say to what you were saying before, I also saw that the first like the incubation period or whatever, that's when you're most infectious to other people. I heard, is that true? Like those different things?
So you're most infectious when you're symptomatic.
Oh really?
Yeah.
Okay.
So so the difference, one of the differences between influenza and COVID is that the primary spread for COVID is symptomatic spread. There is asymptomatic spread, but the media is so into telling people that it's asymptomatic spread that it just made it seem like that's the primary driver. It's not. It does occur, but it's not the primary. The thing with the mask, so it's true about touching your face in the mask, but the thing is, remember, the airborne is the #1 way COVID is spread, not as much from surfaces. So if you touch a surface and there's COVID there, and you touch your face, you could get it, but the chances you're going to get it from something airborne is more. And plus, you want to use the mask with hand washing and social distancing, like all of them together. So it's true, yeah, if you touch your mask a lot for your face. And the other thing about, you might read about masks is the CO2, that's been refuted, and the bacteria, you know, the scientist that did the pandemic, I think she said something about inhaling bacteria. I mean, I've never heard of such a thing. Scientifically shown to be like a fact. I mean, yeah, the mask is going to get dirty, so if it's a cloth mask, we should wash it. I mean, these are disposable. I think it's terrible that we have to wear them for several days, but really, what's there's just not enough supply, you know, to keep. I mean, I would use one of these for sometimes every patient, you know. But now I just wear, you know, light. There's some studies that show that light can disinfect masks, UV light. The only risk is the more light that's exposed to the mask, it damages the mask over time, but it does allow you to disinfect the mask using light. So, yeah.
I've heard something like along the lines of you wear a mask, it's kind of like this. Like this mask obviously isn't as effective as other masks, but I've heard that if you cough in a mask like this, that's just a cloth mask, it actually spreads the virus more. It makes like the particles smaller, that the particles can actually escape the mask. Is that true, or is that just?
So on the, I didn't go over it, but on the airborne slide, so when you cough, the heavy droplets fall to the ground. The small ones go further and fall to the ground, and the smallest ones just kind of float around for a while. So when you have a cloth mask and you cough, it's going to trap all the big ones and the small ones. And the very tiny ones, some of them are going to get through.
Okay.
Yeah, I mean, but it doesn't really aerosolize. What you're saying, it's not an aerosolizer.
So it doesn't make it worse.
It doesn't make it
Okay.
worse. Yeah.
Oh yeah, I saw that this one pathologist guy, he said that it travels like 30 feet and that masks are like pointless. Like I saw that on like the news somewhere about how it was like some leading pathologist guy that basically said that masks are pointless because it doesn't like stop you from getting infected at all basically, because the particles are too small to like hold them, except for like N99 or N100. Like I saw that. And did you see anything about that at all or no?
Yeah, I have seen some reports from even like people in science saying things like this. I mean, the N95, I was wearing an N95 all the time, and I was just getting like headaches every day, and I had to stop doing it, you know? Then they have the study that shows, like, for me, it doesn't really make a difference, but if I'm not doing something like that's going to cause a lot of mist, it doesn't make a difference in N95 or this mask. So even though the N95 filters out 95%, it may not necessarily be better than this mask if you're in a low risk situation. But you're right. I mean, it doesn't fill out 100%, That's why you have to use it with social distancing. Yes.
I have two questions. So the first was like, SARS one was like the one that came out with Hong Kong, and like I think I saw a documentary about it where like they could like one guy went into the hotel and he was infected and he infected everybody. You could like trace it around the hotel. It was really like how it spread. And then the COVID-19 are dealing with now like SARS-2 kind of thing around. So the only real difference between them is that SARS-1 was like an infection that caused like more kind of severe like respiratory responses in the majority of people who got it, and that's kind of like the difference between the two. And then the other question that I had was, I think you mentioned this about the trials that the people who were like getting tested on and like with the vaccines and stuff like that, it was like they were trying to get as many different people as they could, like different age groups and that kind of thing. And so kind of the concern is with how they're going to be rolling out the new vaccines is that if they're going to be kind of, okay, healthcare workers are going to get it first and older people are going to get it first and people in the medical field are going to get it first, then when we find out if there's issues with the vaccine, then like the people that we need or like the people who are most susceptible are going to get it first. Like that sounds kind of concerning to me. So yeah, like I was not sure, like I don't know who's in charge of like that kind of like planning thing, but that just sounds a sketch.
That's a good point. I'm gonna remember that. And they say, hey, you get this.
Pandemic.
So the first question, so the SARS-1, as far as the syndrome is very similar. I think one of the differences is, I can't comment on it. Is it like more viral? Is it more cause worse like lung infection? SARS-1 and 2. I'm not 100% sure statistically. But one thing that's different is that the R0, which is the reproduction number, is lower, meaning that it didn't cause a pandemic. So for whatever reason, it wasn't as infectious as SARS-2. So that's one main difference. Because it caused an epidemic just in that area. It didn't make it, I think they did find some cases actually, maybe, but not really enough for them to call it a pandemic. They found some, I had it on that slide actually, that, like the exact scope of it. And then the question about the vaccine. So yeah, I mean, I haven't heard anything anything about mandatory vaccines, So, and then I read something that I think Dr. Fauci said about, get the vaccine, you should still wear the mask. I mean, I don't really know who's going to get the vaccine, even like if it's not mandatory, to be honest with you. Like I said before, it'll probably be, even if it's healthcare workers and high-risk personnel, probably the people that are going to want to get it are the people that are in the, 220 times higher than your age group death rate and higher than that. You know what I mean? Those people probably, I mean, if that was me, I'd probably be like, well, I'll take a vaccine. Because if I get this, like a 200 or 600 times more chance of dying than like a 29-year-old. But I'll get it. So that's like going to be the mentality of that age group, those age groups.
I had another question.
Wait,
Let's, wait, so 2 more questions. Raquel, you want to ask 1 more question? Okay, and anyone else?
you had one, right?
Oh, no, it's okay. I
Once
forgot.
again.
Anyone else? All right, Sally, Jasmine, and Raquel, last questions.
Okay.
What is the mortality or fatality rate of SARS-1 compared to COVID-19?
Oh wow, you're trying to stump me here.
Let's right here.
Follow-up.
Yeah, so the case, so it's 3%. So that was so that's going to be for the worldwide. The case fatality is 3% for SARS-1. So for SARS-2 worldwide, it was another slide. It was like 2. It was like 2 point something, I thought. Disinfection. Here we go. 2.3%. Yeah, so it's a little bit lower.
So doesn't that just mean that COVID-19 is not as dangerous?
Yeah, I mean, the thing about it too is, so this is over a small period of time. So, I mean, I don't know when they calculated the fatality rate for STARS 1, but it might not have been just less than a year. Because fatality rate is over a period of time. So the other thing is, if you look at these statistics, I mean, I could have went to, like I said, I only have limited access. I have the access to the same data you have. That's why my bioinformatics friends are like, I just want to call them, what are the numbers, you know? I mean, you can go to 3 different websites and you can come out with, 1.9%, 2.4%. So, I mean, yeah, you're right. The fatality rate's higher, slightly. Yeah. Okay.
Go first. Well, I'm a
Eric, speak up.
Yeah, yeah. Oh, I'm gonna keep it to like things that relate to all of us. Like, what's your opinion on, I guess like in-person classes and how like the universities are handling everything and people struggling with, I guess, like isolation and like struggling with online classes, because especially now, I think with technology, our like hyperactivity rates are like increased like over the years, like we have like less attention and everything like that. What's your opinion? How do you think us, like, since we have such a low
Yeah, I think the biggest risk is probably to the community, So I think, individually, unless you have a chronic disease, I wouldn't be worried. I would stay 6 feet, don't go in large groups for long periods. I think the hardest thing is outside school, It's probably less safe for you guys when you leave school and go hang out than when you come to class. So I think everybody learns differently. So if you're the type of learner, especially young kids, if you're the type of learner that needs to be in class, if it was me, I would go to class. I can't tell you what to do. I don't know everybody individually, but you're in a very low risk group, and the risk of severe infection is very low. And there's all these precautions that the university is taking. We could say they should take more or less precautions. Anybody can say that. No matter what they do, people can say that. But I think they're really taking a very measured approach to getting students to go back to school, because I think and I don't know, I want to say many, I don't really know how many, but for a group of people, not going to school is going to affect them worse. So not getting COVID-19 than anything else. It's going to be the biggest repercussion 5 or 10 years from now is going to be the fact that you're a type of learner that needs to learn in person, and you weren't able to go to school because someone told you that you can't. You couldn't make that decision for yourself. I think that's the biggest risk.
I know it's like also my follow-up because of the family medicine specialist. Like, how are you seeing it affecting because just like socially as well? I don't know if you like a lot of these patients are the children.
I don't have a lot of kids. I do have from 14 to 18, I have some patients. I just think in general, even for young adults, I think the thing that I see most is not COVID-19, it's anxiety and depression. And just stress from work and just, the whole stress from everything. It's just like, for many people, it's just like the straw, but it's just the extra little thing. So then that goes back to going to school. What's the risk? Is the risk to get COVID, or is it everything else? And I think for your age group, probably, like I said, unless you have a chronic disease, it's probably all of the restrictions.
Yeah, because it's happening right now, at least especially where I'm from, Miami. It's like a lot of Hispanic families, the children live with their grandparents, all in like one household. So they're like, it's not like happen on top of that. Like, it's not get everyone sick, and then kids aren't going to school, and then they're lonely, and have no friends, and they're flat.
So that's a situation where, like, if you live with someone who's older, or they have a chronic disease, then yeah, you have to think about that. Are you going to go to school or not? Because I think the biggest risk is, for young people, is gathering in small groups, then having a super spreader event, and passing it on to somebody who's 50 or older. And that's the risk for the community. You've got your question back?
Yeah. So my question was, what is the risk of young children spreading Because I've read that it's very minimal, but I'm not sure.
Honestly, I don't think we know, because we definitely it happens, but I don't think, that was another thing that people thought was like the primary driver of infection was like young kids, and I don't think that any of the studies have shown that that's a fact. I think I don't think that it's negligible, but I don't think that it's like a big, like one of the larger risks. Yeah. Everybody, did you have
I
one?
remember.
You remember?
Yes.
Okay. who's the last
Okay,
one?
so.
You can talk to me after. I won't leave anybody, have any other questions.
We're also going to take a picture afterwards, so no one leave.
So you can ask me.
During the slides, we were talking about like the different tests that have that lab have done with like different coronaviruses and like in general, like different tests with vaccines and stuff like that. I'm not sure like we have like about half a dozen vaccines that are in different phases of testing. I'm not sure, are they all like out of the States or like just across the world, like different companies that are making these vaccines?
I don't know what they're private companies. I don't know actually what each company does.
Okay, so the reason I asked that is because a lot of like concern that I've been having about like how like what we're learning from this pandemic and what we're going to be doing moving forward is like in the States, I know in general kind of what the rules are about like if you're in microbiology or like if you're working with like different viruses and bacteria, like what kind of rules there are and like what we're doing to mitigate the kind of chance for human error in the States. Like I understand what our rules are, but like in other countries, I'm not really sure what they're doing, and I'm not sure like what kind of like there's a lot of like trust going on with that. So like I'm not sure if there's like some like big I don't even know if the WHO does, but I don't know if there's like some big like global body that like keeps that in check or like how that kind of works with how countries interact with how they like testing the viruses. So it seems to be
So,
Well, for Pfizer and Moderna, they have to be US companies because they're going through like the FDA, right?
yeah, they all.
So those are US companies. I think
Yeah.
California.
Yeah, that's kind of the overseeing body is the FDA, so that's who's gonna have all the regulations and should require them to show, you know, what are the ingredients, how they do the study, you know, they have to consent, all these types of things, so, yeah. So that is a valid concern, that's, the FDA should have things that they can be regulated about that. Very good, intelligent questions.
All right. So thank you, Dr. Linda.